I think for the super users, which is what we are, bringing in this AI becomes a little bit more of a finessed tool.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Mona Dagher and myself, Dr. Hadi Saheb.
Bienvenue à EyeCan, un balado sur l'ophtalmologie sous un angle typiquement canadien, avec le Dr. Hadi Saheb et moi-même, Dr. Mona Dagher.
Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support. Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan.
We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Hey there, eye care enthusiasts. It's Mona and
Hadi, back at it again with EyeCan.
You know it, Hadi. Today's episode is going to be a real eye-opener, pun intended.
Mona, always with the puns. I promise, folks, today's discussion will be just as sharp as Mona's great wit.
Hey, we're here to keep it both informative and entertaining, right?
Absolutely. So whether you're a seasoned ophthalmologist or just as fascinated by eyes as we are, you're in for a treat.
On today's episode of EyeCan, we enjoy a conversation on artificial intelligence with Dr. Delan Jinapriya. Dr. Jinapriya is an ophthalmologist specializing in glaucoma and cataract surgery. He serves as the Fellowship Director of the Surgical and Medical Glaucoma Fellowship at Queen's University and is an assistant professor at Queen's. Additionally, he is the Medical Director and CEO of the Galen Eye Center and the Medical Director of the Glaucoma Society. Previously, he chaired the Canadian Ophthalmological Society skill transfer courses and has been a reviewer for the Canadian Journal of Ophthalmology, the Journal of Glaucoma, and a grant reviewer for the Canadian Glaucoma Research Council and the Canadian Institute of Health Research. As a key opinion leader in ophthalmology, particularly in glaucoma, he advises Ontario's Health Technology Assessment Program on the value and funding of new technologies.
He completed his medical training at Queen's University and his fellowship at University of Toronto. He spent the first 15 years of his career focused on delivering and training ophthalmologists to deliver tertiary level surgical, procedural, and medical management of glaucoma.
Dr. Jinapriya became a physician to contribute to the betterment of people's lives daily. After specializing in ophthalmology, he made it his mission to reduce preventable vision loss, recognizing that vision significantly impacts independence, productivity, and happiness.
Saving vision or delaying its deterioration by even a few years has a tremendous impact on a person's quality of life and their ability to lead an independent and maximally productive life. He also believes in order to deliver the best care to people, there needs to be a dedication to continual education and improvement, both for himself and for the field, and for this reason is dedicated to education initiatives through developing and delivering CME programs, training future ophthalmologists, training future glaucoma specialists, educating non-ophthalmology healthcare professionals, and educating patients and their families. In addition to the practice of ophthalmology and being an educator, he is now dedicating much of his energy to finding ways to improve the systems and processes of ophthalmic health delivery to serve more people and save more vision. Having the luxury of being Dr. Jinapriya's good friend for a number of years, I can attest to his dedication to making an impact to patients and dreaming big and imagining a better healthcare system and better healthcare delivery. So I'm so thrilled us on EyeCan.
Well, I thank you both for having me.
So let's jump right into this exciting topic. The growth in artificial intelligence in the past few years has been remarkable. AI is reshaping industries, it's transforming our daily lives, it's evolving very quickly. It's creating many opportunities, but it's also creating some challenges. So it's an exciting time to be in this field, and we are really looking forward to learning more from you today, Delan.
Well, thank you. And, I don't necessarily feel like I'm an expert in AI, but I'm certainly using it. And so perhaps I'm really happy to share what I'm learning as I'm practically diving into it, right? And as you say, going through the challenges and also experiencing some of the benefits.
Delan, can you tell us what are some of the most exciting advancements in AI that have recently impacted ophthalmology?
Yeah, I mean, I think one of the things to take into consideration is that, AI is very good when it comes to images. And ophthalmology, a lot of what we're doing with respect to glaucoma or retinal disease is very image driven. And a lot of our diagnostics lend themselves to being able to be analyzed, in a way that AI can find patterns. So I think we're the right field to really be able to very quickly integrate the data that we already generate and evaluate ourselves and come up with conclusions. I think it's a really easy background, or it's an easy environment in which to apply AI to try and streamline or find patterns. And so, I mean, retina has certainly been doing this for some time, with diabetic macular edema and macular degeneration, and diabetic retinopathy. And so it's been very successful in that realm. I think the harder one has been glaucoma. And so, I'm excited with respect to the way that it can be used for glaucoma. And I still don't think it's been optimized for that yet. And we can go into why. But overall, we have now been using it through Euclid Telehealth for 3 years, but we've been shadow using it. So that means that we have an ophthalmologist look at everything we do, but we use the AI on everything we do as well. And, the false negative rate is what we're most concerned about, because I think we're worried about counting on the AI and it missing something that we would have otherwise caught. And so far, it looks like that false negative rate is somewhere around 1 in 1,000, which is somewhat comforting, right? And so now it's just about, when do you pull the trigger on really trusting the AI as your first layer? And if the AI says there's nothing there, you believe it, so we're right on that edge. And, being the first ones to kind of do that is always a little bit scary, but it's imminent in our practice.
That false negative rate is pretty reassuring, Delan. I'm so happy and reassured to hear that. How would you explain how AI improves the accuracy and efficiency of diagnosing eye diseases? And we can talk about it from a glaucoma lens and from a diabetic retinopathy lens.
Yeah, Hattie, that's such a good question. And I'll be honest with you, I'm not necessarily sure that this particular point of accuracy is where AI has its greatest power in ophthalmology. Okay. And I say that because I think that in ophthalmology, there's a lot of pattern recognition. And if you put whether it's OCT, red fiber layer scans, or ganglion cell, if you put visual fields up, or if you put discs up, or if you put retinas up, I think in a glance, most ophthalmologists know what they're looking at. So if you were really to think about the efficiency of it, I would say for a retina specialist, probably in half a second, they know what they're looking at, right? Maybe even less. Like, it's that quick, that recognition. So I'm not so sure that it's always the accuracy component, although I was surprised at the fact that it can find DME off of a fundus photo. That I'm a little bit surprised at and impressed by. As to, what I have called increased sensitivity, or too sensitive on the glaucoma front, maybe it's not too sensitive, right? Maybe it's just seeing something that we aren't yet seeing, right? But I'll believe that once I know that the driven by fundus photos or disc photos, but we haven't, for example, taken a case that looks like a normal disc, but because of progressive loss of retinal nerve fiber layer tissue or ganglion cell tissue, we call it glaucoma, right? So the more updated versions that we need to see of this AI are going to be ones that are fed cases that over time and with multiple inputs, we've discovered that this really is glaucoma, even though to look at it doesn't look like it. And then to let the AI figure out, what is the pattern here? What is it seeing in the fundus photo that if you had all these other inputs, it somehow figures out that there's a problem, right? And clearly it can do that, because if it's looking at a fundus and it can tell you how old somebody is, it can tell you whether it's a male or a female, it can give you cardiovascular disease risk. How is it doing that, right? Like, this data has been there this whole time. What is it seeing, right? So that's certainly from an accuracy and efficiency standpoint. Well, efficiency is a different issue, because efficiency, we can look at process efficiency, right? And I just mentioned the fact that we have a human being looking at every single one of our scans. Whereas if the human being only looked at the scans that the AI said were suspect or were bad, that human being can now see that many more scans in a day, and all of them really require scrutinization, right? So from a process standpoint, you can talk about efficiency, but if you were to just look at it, beings can do. But I think it's a great tool for us as ophthalmologists, because I think it is actually quite sensitive and it can be quite specific, right? So I think those two parameters are I think it's robust enough and it's sensitive enough that we can use it as a tool in our practice.
I want to ask you a question, and I'm not sure that that you'll be ready to answer it, but I think with you having dabbled, more than dabbled, you having dove into this field specifically with glaucoma screening, I think you'd be suited to at least try to answer. So, being a glaucoma guy like you and being interested in reading about and thinking about glaucoma screening, over the last decade, when you look in the literature, study after study saying that there's no justification, it's not cost effective, glaucoma screening there's no clear, paradigm that works as of yet. And I think a big part of that is that you need multiple data points to make the diagnosis. You can't just look at the pressure. You can't just look at optic disc photo. You potentially need an OCT scan, which is expensive, and so on. Do you think the answer to that question, doing glaucoma screening potentially just with a simple disc photo and then taking that disc photo and inputting it, having AI look at it, do you think the question to that answer will change in the next 5 years?
Yes, I do. And I think you really summarized it well. A lot of the screening programs in the past, have been, and the ones that have been criticized as being cost ineffective, are the ones that are looking at people who are just taking pressures, and it's being done in family medicine offices by and large. And Quigley really speaks to this, where he says, like, look, that's not how you'd really screen for people. Like, it's not an optometrist who's screening, or it's not an ophthalmologist who's screening. So have we really evaluated the proper screening process? Nevertheless, your point is, look, if an ophthalmologist or an optometrist is screening, they're going to run all of these tests, right? Which is quite expensive, as opposed to one picture, AI evaluates whether or not it's glaucoma, right? Which is much more cost effective. So the answer is absolutely yes. And then it would be, can we keep on iterating on the AI such that it becomes that much more sensitive to identifying what is glaucoma, right? So yes. And, we're getting to the point where, you can imagine if AI is picking up off of a fundus photo that there's diabetic macular edema, when for the human to look at it, you can't tell, you need the OCT. You've effectively now eliminated the need for that OCT in order to see the diabetic macular edema, right? So the screening protocol in remote areas no longer requires you to have a $100,000 OCT machine, right? It just requires you to be able to take a fundus photograph, which, quite frankly, we're doing with cameras now that are at $15,000, right? Like, even our old cameras used to be $30,000 and $40,000 and $50,000 and weigh 80 pounds and sit on a desk. Now it's a handheld camera, right? So the cost is definitely coming down. And as the cost comes down, it makes population screening more cost effective, right? So yes.
It's wild to imagine that glaucoma screening will become accessible and justified, because it's such a fear for all glaucoma specialists to just know how many patients are going undetected in the community, and to be able to imagine a world where glaucoma screening will be cost effective and being taken upon by our government agencies and then just put out there is amazing. So great. Thanks for sharing those thoughts. Trying to get into a little bit of specific tools. Can you share any specific AI tools or software that you feel have become indispensable in modern day ophthalmology practice?
I'm not sure that I'd say something is indispensable, right? I mean, I think that ophthalmology has managed to strive for efficiency. And if you look at medicine, I think ophthalmologists they really run very efficient practices, right? And so, absolutely essential to have, I'm not sure is perhaps correct. It might be a little bit, maybe I'm underestimating how much more efficient ophthalmologists could be if they allowed the AI to be its primary screening tool and allowed the AI, for example, to have looked at the OCTs and the visual fields and the let's say disc photos and called whether or not there's progression, right? And so we're not yet at the point where the tool is ready to do that, because the current AI that we're looking at, that's Health Canada approved anyway, the ones they aren't really looking at the OCTs for glaucoma just yet, right? And I think that's going to be pretty critical for the AI tool to be able to do before it becomes indispensable. I think the moment that it does, you're going to see a lot of people start to use it, and you're going to find that it really probably will become indispensable. It really will make us more efficient. But right now it's based on fundus photography. It's good in our screening setting. I'm not so sure that it would be good, for example, in a glaucoma practice where you have known glaucoma patients and you're looking to identify whether people are progressing or not, right? I still haven't managed to apply it in that setting.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes.
Hi, my name is Dr. Louis Racine, and I listen to the EyeCan podcast.
So how do you foresee the role of AI evolving in ophthalmology over the next 5 to 10 years?
I think that the evolution, the key is to start using it. And then as you start to use it, it's also going to be one of these things where, for those of us in academic institutions, the academic institutions are even looking for us to use their supercomputers and to develop our own AIs, right? And so the potential then, once you're using it, it's already in the clinic, and say, look, I'd really like to see how it could evaluate my, let's say, my OCT max, and whether or not the CME is worse or better, the DME is worse or better. And the same thing on RNFL scans or ganglion cell scans. So instead of just looking at the dots, which is a form of, the progression analysis we have is relatively powerful, right? Back in the day, we'd line up all of our visual fields, you'd line up all your OCTs and try and see if the numbers are changing, right? And so we have to give credit where it's due. There are good progression analysis programs that aren't quite AI, right? So the next step above that, what does AI really look like? How does it really improve upon that? That's a really good question. And I think what it's going to be is it's going to be a tool which actually makes that decision as to whether or not overall there has been progression. So I think it's going to be that summative kind of, it's a program that layers on top of what we already have to give you that final, when you open the file, there's either a green check mark, there's a yellow exclamation point, or there's a red stop sign, right? To tell you whether the patient's perfectly fine, nothing's changing, hey, something might be off, or there's something bad going on. I think that's quite possible to see happen or have happen in the next 5 years.
I want to unpack that a little bit, because some of the progression analysis softwares, and I agree with you, some of them are fantastic. The summaries I found, I still find, as somebody who, looks at glaucoma progression all day, every day, and absolutely passionate about it, I don't look at them. I don't look at the summaries, because I find that my interpretation, having known the patient, looking at what's changing, is it just the RNFL, is it just the ganglion cells, is it a combination of all of them? Do they correlate? What's the pressure today? How old is the patient? How long have I been following them? I find that my interpretation is not always in agreement with the summary statements. And is your prediction that AI will be able to do that any differently than the current summary statements from the progression analysis softwares that we have? Or, I mean, what's your feeling about that? I see you laughing a little bit at my comment, as if you
Agree with you.
agree
As
with
if
it.
I agree with you.
Exactly.
Yes, as if I
And
agree with you. Yeah.
and so when you're thinking about how AI might do this in the future,
Yeah.
do you think it will be able to integrate our clinical judgment in a way that's beyond what the progression analysis software is doing today?
Yes, and here's why. So the reason we don't like looking at, and we probably completely ignore whether it thinks there's progression or not, is that you just mentioned all these other factors you take into account. And the point would be that the AI would take into account all those other factors that you just mentioned, which our current progression software simply looks at whether the superior RNFL is progressed based on numbers, just based on sheer numbers. Is there a chance that this is statistically different than the test before, right? And so that's where we then look at the raw data effectively and say, well, overall, I don't believe it. There was a couple that were bad, then it bounced back up, and then I'm also looking at these pressures. These pressures have been great the entire time. This isn't all adding up. No progression here, right? And the point would be that the AI program would pull in your IOP from Goldman. It might pull in your IOP from EyeCan. It might pull in your IOP from whatever other form of IOP way that you're doing it, taking into account corneal hysteresis, perhaps, pachymetry, whatever else, right? And through all of those inputs, it then spits out, I think this is progression or not, right? Which is effectively what you did. You just said, no, it's too simplistic to just look at these 4 numbers or these 3 numbers, these 3 parameters. I'm going to take into account at least 6 more parameters.
Well, my next question was actually had to do a bit with the limitation and challenges of integrating AI into ophthalmology. So I guess in glaucoma, there's so much to be factored in before a decision is made. But if you think of retina, and if you look at the images, they're really just looking at a fundus image and checking the progression. And that's probably why in retina it has developed much faster than in glaucoma, and even tons and leaps forward in comparison to cornea, where we don't have much going on. So do you think that in the future we will see more AI being integrated into the practice of glaucoma and cornea specialists, not just for retina?
I mean, the answer is going to be yes. I think the first barrier to overcome is going to be whether or not these programs are willing to communicate with each other, right? And so you need the ability for your AI program to pull automatically from either your EMR, where somebody has entered the data, or straight from the actual source instrument, right? Whether it's your topography, whether it's your biometry, whatever it might be, so that it can actually then do its analysis. Otherwise, if you have a human being trying to enter 6 or 4 or 10 parameters in, it actually slows you down, and you'd limit your use of the AI. Very interestingly, when we started off with the AI, we would have a model where you'd pay for every time you use the AI. And we were pretty judicious in when we used it, right? And then they said, look, how about this? How about you just pay a flat fee and just run it on everybody? Okay, that was great. That allowed us to do that. But again, it takes time, because we'd have to press a button and wait for the AI to work, right? So then what we did was we had it integrated such that the data automatically went up to the AI as soon as the tech was finished doing all their scans, so that by the look at the chart, the AI answer was in the chart. So all of this requires our EMR to be able to work with the AI company, right? And allow for that community, and with the hardware company as well, right? So you can imagine we need Heidelberg, Zeiss, Topcon. We need them all to be willing to open up, or they're going to have to develop their AI in proprietary AI, but then it might not pull in all the other things you need, like your tonometry, your topography, whatever it might be, right? So That I think is a really big limitation to tool, is the fact that we do have so much technology, we do have so many vendors, and can we get all of these pieces to communicate?
Such an important practical pearl about kind of your journey and those small things that you mentioned, but make a massive difference in terms of the practical experience for the eye care provider. So thanks for sharing that. I'm so curious to hear from you what you feel you know today about AI and ophthalmology that you didn't know before, you pressed on your first AI button with one of your patients. What do you feel you know today that you didn't know X years ago before you started?
I think, interestingly, as much as AI has been used a lot for retina, and you'd think that, we'd be pretty used to understanding that AI is pretty powerful for retina, I didn't fully appreciate how it could possibly diagnose some of the things that it's calling, like edema, right? I mean, on a fundus photo, like, how does it not just say, well, this is just a poor quality fundus photo, right? Like, why is it calling this edema? And more often than not being correct. So that was surprising to me, that there's something that it is seeing. And I thought we'd definitely be able to pick up on that pattern ourselves. On the glaucoma side, I think it's pretty good at, so I'm not too surprised at when it calls it there. Although in all fairness, one of the things that could be concerning in a way is that I think if it's too sensitive and you're not a glaucoma specialist who's looking at it, and you're a primary care person, are you going to be prone to over-treating, right? Because it's called a larger disc with a 0.75 or 0.8 cup. It's called it glaucoma, when in reality, there's still 100 microns of tissue, right? And that's the danger, I suppose. And I mean, being a glaucoma specialist looking at it, we're quick to look at the things and discount and say, no, that's fine. But, in order for this to be broadly used, it's not just going to be glaucoma specialists or retina specialists using it. It's got to be other people using it. And in some places out there, it's going to be a nurse. That's the best that the community has, right? They're going to have point of source AI, and it's going to say, yep, that's glaucoma. And they're going to be like, okay, here, please start this drop, right? Like, that's the best that they've got, right? So that's one of the downsides, right? And we're going to have to obviously the AI will have to be forced to improve in order to decrease the consequences of overtreatment.
How do you feel the profession, whether it's the AI professionals, the ophthalmologists, provincial agencies, how do you feel any of these stakeholders in kind of the AI journey are addressing concerns about, one, the ethical implications, and two, the data privacy issues, which are part of ethical implications as well, related to AI and ophthalmology?
Well, I'll tell you right now, for example, from a privacy standpoint, when we upload photos, they're uploaded with a serial number, not a patient name, right? So the AI company, even though that's all being processed through their software and hardware offsite, all they have is a serial number. So the same level of privacy that we expect and have adhered to in our EMRs still holds true, I think. And I'd say the same thing is true even for the AIs that are built into the cameras, and on the camera will give you the answer. You're not entering the patient's name per se, right? You can literally just take a picture and it gives you an answer. So I'm not sure that the privacy has necessarily been breached or even has a risk of breach in that particular circumstance there. That was one. The ethical part, what ethical, could you maybe give me an example of where there might be an ethical dilemma?
One that comes to mind is, the applicability of the AI platform to various ethnic groups, for example, in Canada, right? So is this, is there a bias in the AI software that could disadvantage any ethnic groups that are part of our community in Canada?
Right. Well, I mean, that's a great point. I mean, for sure. And the only way for it not to is for us all to be comfortable with identifying ethnic groups, stating an ethnic group as it is, and then building the database on that ethnic group, right? Otherwise, we're all prone. I mean, even if we take a look at our normative databases, right, they have been biased to this point. And, we have to decide to say, no, we're going to actually subclassify this. And then people have to be comfortable saying, yeah, not what you identify as, well, my genetics state that I am this, right? So unethical kind of situation that we're dealing with. I think it's a reality that, we are more heterogeneous, as homogenous as we are as human beings. There is heterogeneity that has to be respected, right? And I think if we're comfortable accepting that, then I think we can get even more true answers, right, from our AI. And in fact, I think it can be even more sensitive in that regard, right? You think if you enter certain ethnicities, and it can take into account, risk profiles as well.
Is AI and glaucoma diagnosis, is it ready for prime time?
Oh, Hattie, I know you're not going to like this answer, because the answer is it depends.
Of course.
Right? It depends, right? It depends on what we think prime time is. If we think prime time is broad distribution for everybody to use, right? If you considered prime time to be, hey, upload a picture into whatever cloud, and it gives you an answer as to whether you have glaucoma, right? And now you think you have the answer. If that's what prime time is, I would say the answer is no. Okay? Because I think it's too sensitive. I think it's overcalling glaucoma. I could be wrong. And 5 years from now is what it's going to take, because some of those people who the AI said was glaucoma, and I said, no, it's not. And if they turn out to be glaucoma because of other parameters that I trust, such as a change in RNFL or ganglion cell, well, okay, all of a sudden, that AI was ready for prime time in 2024, but it took me till 2029 to truly, is it ready? Are we ready to count on it? The answer is yes, because we're a screening program, and we would rather it be more sensitive and then look at those cases and say, no, it's okay. So in our realm, it's actually quite good, because we still have an expert looking at all the cases, or at least is going to look at all the cases that the AI claims are glaucoma, right? So in our realm, yes, it's ready. It's ready.
Classic glaucoma guy answering it depends, but it's a good one. It's a good one. I appreciate that nuance. So my next question is kind of a follow-up to this, because we go to, most of our meetings have some talk on AI. So clearly it's on the radar of, our colleagues across the country and internationally. But knowing what what do you think we need to do differently, if at all, with regards to training, education, whether it's, peer education or learner education, academic programs? What do we need to do to prepare our colleagues in our communities for the integration of AI in their practice? Because it sounds like you're ready for this in your realm of having Euclid and focusing on screening, and you feel like it's pretty soon that you'll be ready to recommend this more at large. So what do you think we need to do training wise to prepare our colleagues to be ahead of the curve here in Canada compared to elsewhere?
I don't know that I can give you a direct answer on this, because I think one of the dangers is that if you don't learn the fundamentals of how to make a diagnosis, and you become too dependent upon a tool that is giving you the diagnosis, you don't know whether you're right or wrong, really, right? And so I'm not sure that we're ready to stray from our current way of scrutinizing and making our diagnoses based on forcing people to look at a variety of parameters. I think that the utilization of a tool in the same way that somebody might be using a progression analysis tool, they fundamentally, however, should know how to look at the data and evaluate whether they agree that it's progressing or not progressing, right? Regardless of what the program says. I think we have to ensure that the background is sufficiently strong in our graduates that they feel comfortable disagreeing with the AI, right? And so AI integration is going to be, it's like integrating a new piece of software. It's like integrating a new device. We're pretty good at that. I think the software part is harder. I think we all struggle with the fact that we have so many diagnostic tools, and how do you get them all into one place? How do you maybe get different branded products all into one program? That doesn't really exist for us. So in that regard, it's going to be a little bit challenging, I think, to truly integrate AI into your typical glaucoma practice, or your typical, ophthalmology practice. Front end, however, if we were to rethink how we approach eye care, the fact that there's a significant portion of Canadians who haven't had eye exams, and you say, well, why is that? And where's the other point of entry? Could they, for example, have had a picture taken at their family doctor's, and for those who flag, the family doctor says, you must go and see your optometrist, or you must go and see an ophthalmologist, for those who are refusing to go because they're between 18 and 65 and have to pay. But at the family doctor's office, that one click allowed the family doctor to insist upon something. Like, we can, there's a way in which, in that regard, you can more broadly utilize this AI for ocular healthcare, right?
Titler,
I think for the
produced by
super
John Allaire
users, which
from
is what
Allaire
we are,
Strategic Works.
bringing in this AI becomes
EyeCan is available on
a
Apple,
little bit more
Spotify,
of a,
and Google
of a finesse
platforms.
tool.
And of course,
It really
through the
is
COS
something
Practice Resource
that
Center.
isn't necessary.
Some episodes this
It's
season will include
nice.
relevant links and
It
show notes, so be
provides
sure
you
to
with
check
added,
episode descriptions to learn more.
Information.
Thank you for
to
joining
make
us
you
this
a
week.
little bit more
We look
efficient,
forward to bringing you
right?
more
I think
episodes.
that's how probably subspecialist users would look at it. Same thing, we look at using it in cornea, using cataracts. We're talking about, we're already so good at our outcomes. Yeah, our outcomes are at least 95% of the time you're getting outcomes that you're quite happy with. It's the 5% that you're wondering, hey, we really missed on that. And would the AI help reduce that? Let's say the AI cut that in half. Okay, so now you're up to 97%. Is it that big of a deal? Right? So it is. It is. I mean, you can't take the attitude that you're not going to fight for that extra 1%, right? We're a tool in that regard, right? But hey, there are a lot of things that we take for granted, and there's a lot of, we take, I think, the Askers website and all the fabulous analysis that it can spit out for you, which it does for free. I think we take that for granted, and I think that AI will be in the background for a lot of these things. I think that a lot of them will be doing that. So it's probably, maybe I'm underestimating how it can truly be integrated into various aspects of ophthalmology. And I'm maybe being a little bit too focused on my glaucoma practice, right?
Well, I love your practices. Your initial answer was, continue to train people to be excellent at using the non-AI aspects of the evaluation to make diagnoses, so that you're ready to disagree as we integrate this new technology. I thought that was interesting and insightful. So nice.
Thanks.
Absolutely. Great judgment. And it should be the way that we should continue practicing medicine. Can you share any real world examples or case studies where AI has actually made a significant difference?
Yes, we are running a screening program, and there have been times when I have not felt that the discs that I was looking at were glaucomatous, but the AI felt it was. So we brought them in for a second round, and the second round involves an OCT. The first round is just purely fundus, right? And the OCT certainly did agree that it was glaucoma. So, and you'd think that as a glaucoma specialist looking at some nerves, like that I would have agreed more with the AI, let's say, right? But it does occasionally, and I told you it's more sensitive because I do think that on larger discs, it's calling larger cup to disc ratios. And I think that's where it's biased towards. But at the same time, it has caught rims that I just didn't think were that bad. And the OCT agreed that, yeah, no, that's significantly thinner than it should be. And the ganglion cell also agreed, and so in that regard, there's an example of where the AI did make a difference, where I would have said, no, you're fine, 2 years, right? Whereas now we are in fact doing something now. So I think the reality is that with our society getting to the point where we're living so much longer, sooner you can intervene and offset the rate of degradation, the longer this person can keep that vision. And 30, 40 years with a chronic disease is a very long time, right? Our vision we're more dependent upon it, I think, when we are more frail, when we can't move as well, when we can't hear as well. That's when you really want these senses. And at that time, to have it be functioning at 50% or 75% or 25% it's not ideal. So I think we do have to play a little earlier. We do have to think more about prevention and early intervention. So in that regard, I would say the fact that it has helped us identify people earlier than I otherwise would have, I'll take that as an example of where it has helped or been beneficial.
That's awesome. Thank you, Delan. So as our final question to this great chat, we like to ask a little bit about the man behind all these brilliant thoughts and ideas. And I, as your friend, I have the luxury of knowing that you're an interesting and balanced man with lots of exciting outside interests. But we'd love for our guests to hear a little bit more, cast your hobbies. What can you share with our listeners about the man behind this conversation?
Well, I don't think I'm that interesting, quite frankly, but I will share some things. I mean, I do think that staying physically fit is really important, and so I make it a habit to do something physically active at least 5 days a week. I'd like to get up to. I don't think seven's necessarily good, but let's say 6, right? And I've altered my life in order to try and do that before the day starts, because I find that I can never quite predict when my day is going to end, and I'd like to be at home to, for the end of the day. And so I do get a workout in the mornings before I get to the clinic. The only exception would be my OR days. In terms of books, I've been, I think, heavily influenced and impressed by Robin Sharma. A lot of his books dating all the way back to The Monk Who Sold His Ferrari had a very big impact on me. And perhaps it was timing as well. Like I started to read Robin Sharma in my 40s when you're questioning whether, what they call the midlife crisis, if you will, but you're really questioning how you got to where you are and whether you want to continue doing what you're doing and what is the future, how do you want your future to look? And very inspirational kind of person in terms of having the right attitude towards life and your approach to anything, really. And then in terms of podcasts, I've been quite influenced by Patrick Bet-David, the PBD podcast. I've really been part of that for the last 10 years, listening to him. And I found the content that he was producing as I was trying to run my practice and figure out things that I'd never been educated on, like hiring and contracts and incentivization schemes. I mean, these are all business practices, right, that we don't know anything about. And yet, as soon as you run a practice, that's what you're doing. You're running a business, really, right? And so I found him to be incredibly informative. And, in a time where I think the media is harder and harder to know whether some other sources that are providing, a look at things, a critical look at things. And so I've found that particular podcast and YouTube channel to be very, very helpful. There are others. I don't know how much you want me to really get into, but I do enjoy, while I'm driving, listening to the podcast. I find that's a good use of time. I've managed to cut out media. I don't do social media. I'm easily distracted. So to have a Facebook or anything else is just not good for me. And I'd rather spend my time in more productive ways. So I've just cut that out altogether. I never started it, quite frankly, right? And I'm electing still to stay off of it. Sometimes to my detriment. There's lots of things that people know about, like concerts that are happening and festivals, and I just don't know. I've got to count on knowing people to tell me, but I'm okay with that. That way I have people who love to do great things, and if they're recommending something, I go along with that. So.
Just keep a few social media addict friends in your inner circle, and it'll compensate for that. Kudos to you. That's amazing, and a special kudos for working out 5 days a week. I've recently challenged myself to do a workout on the morning of my ORs, and never having dared to because of all the things that we worry about. and it went so smoothly. I was
Really?
better. I was better that morning, and it's just opened this door of possibilities for me that I've loved. So
Was it
dared it,
cardio or was it like
heavy
strength training?
weights,
Heavy
strength weights,
weights?
including upper body. I couldn't believe it. I just, yeah.
Wow,
Anyway, try it. You never know. I was pleasantly surprised.
that's interesting.
It felt like I was kind of parachuting into your present, which is hopefully our future. And it's been so insightful. And so really thanks for sharing many of the things that you've learned. And I know our listeners will really appreciate this chat.
Well, it's been such a privilege to be asked. It's an honor, and I'm humbled, really, to be here. And I hope there's something useful that the listeners will gain out of it. And again, thanks for the support and the positive kind of reinforcement along the years, encouraging me to pursue some of these things that are maybe a little bit of a dream, but a lot of these things it's interesting how when you try things, you've got to try, and some things fail and some things work, right? And when it works, it's kind of nice. It's kind of nice to see things evolve. And yeah. So anyway, I really appreciate this opportunity. Thank you.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes. Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan. Thank you from the Canadian Ophthalmological Society.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan is available on Apple, Spotify, and Google platforms, and of course, through the COS Practice Resource Center.
Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more.
Thank you for joining us this week. We look forward to bringing you more episodes.